Hello and welcome to the Downsized. I'm excited to welcome Harith Rajagopalan, and I'm going to let you meet him in just a minute, but we are actually live from the floor of Obesity Week in Atlanta, Georgia. Lorraine and I are spending the next 2 days interviewing all the movers and the shakers, the scientists and the doctors who are changing obesity medicine, and we're super excited to bring it all to you. Before we get started, I do want to say I am not a doctor. This is not medical advice. Are you actually a doctor?
I am actually a doctor.
But he's not your doctor.
Yeah.
All right, so everything we're going to talk about is stuff that's coming, and Harith will be very clear about it. It's not in your doctor's office today, but it's coming. So this is super exciting future of obesity medicine stuff. If you haven't already, please take a moment to like and subscribe, hit the alert bell so every time we publish a video like this, you'll be learn. So Harith, first of all, who is Harith?
Who is Harith? Well, my name is Harith Rajagopalan. I live in Wellesley, Massachusetts. I'm married to a woman I met in college. We've got 3 boys between the ages of 11 and 19. And I am a cardiologist and an MD, PhD physician scientist. And about 15 years ago, I became really passionate about trying to identify and treat the root cause of obesity and metabolic disease.
And so what brought you to that?
What brought me to that was actually being a physician, taking care of patients in cardiovascular clinic, people who had coronary artery disease and obesity and type 2 diabetes, and realizing that we're treating each of them with individual band-aids, trying to be able to manage a whole slew of medical conditions that are developing and progressing, but not actually getting at the underlying root cause of it all, in order to try to fix the thing that's causing all of these downstream problems. Now, at the end of the line, all of this leads often to cardiovascular disease, and that's often the thing that threatens the long-term health and lives of people with obesity and metabolic disease. But upstream of that, there are so many warning signals and so many signs. What became clear to me is that this is not 10 different diseases. This is one common disease. I became obsessed with trying to figure out if there was something that we could tackle at the upstream root cause of that disease to fix it overall, rather than to manage the heart attacks and the heart failure and the liver disease and the kidney disease and the eye disease and the neuropathy that are resulting from all of these conditions.
What I would tell you is thank you, and people who watch know my personal story. I started taking Tirzepatide. Lorraine's going to walk by the camera.
Yeah.
I started taking Tirzepatide 2 years ago because I woke up one day and realized my mother had died 3 years older than I am from heart problems, from obesity. She just dropped it.
Okay.
And there is no doubt in my mind if we had had some of these options available to her, she'd still be here. So
my father and my uncle had type 2 diabetes. They were taking their medicines very regularly. And when I was a kid, what I observed was my dad dieting and exercising and taking his medicines, but I also observed that the disease kept progressing, despite taking all of these medicines. And what that led me to realize is that you can do your absolute best, but you're fighting against a progressive disease. And that became something that really motivated me to try to find a better option.
Well, but we appreciate that as a community, because so many people have been blamed and called lazy and they're not trying. And so to hear doctors say, hey, no matter how hard you worked, it wasn't working, right? There's medicine that can help this. It's important. It's empowering.
When my dad's blood sugar was high, even though I saw him taking his medicines all of the time, and his doctor would tell him, hey, you're not trying hard enough to control your disease. That's so... it's so disempowering for a patient. It's so disenfranchising. And honestly, you can appreciate why the physician might say something like that, because the physician has a limited set of tools available to him or her. And if those tools don't work, you can imagine how a physician is going to blame the patient for not doing a better job, rather than blaming the tools that they have available to them. And I think what I was able to think differently about, because I was a cardiologist, because I was passionate about research and science, is maybe the tools are the problem rather than the patients and their willpower.
We appreciate that, man. Thank you.
I've got a nice little story about that, actually. One of my patients, and what really got me started down this road, was a patient who had obesity and cardiovascular disease and type 2 diabetes. We know there are many, many people like this in this country. And he kept telling me how hard he worked to try to control his diet, control his blood sugar, but despite all of his efforts, it wasn't working. Somebody recommended a bariatric surgery to him. And I didn't really know, because I was a cardiology fellow at the time, very much about bariatric surgery back then. I saw him 3 days after his surgery and visited him in his room in the hospital. And the hospital cafeteria had sent over a cheeseburger and fries for his dinner. And I realized, like, oh dear, he said, you know, doc, the weird thing is I don't even want to eat that. I have no appetite for that.
Right.
I went to his chart. I saw that his blood sugars were normal. I said, oh wow, the nurses are doing a really great job of controlling his blood sugar after the surgery. And they said, no, he's not on any of his medicines. His blood sugars have been totally normal immediately since the surgery. And then I went in and I asked him some more questions. I'm like, they say your blood sugar is completely normal. He's like, yeah. And you know, the funny thing is, like, I'm not hungry to eat.
Right.
Now, that's fascinating. Like, even if you're not a researcher or a doctor, like, there's nothing that we learned that could possibly explain how you could do this surgery and now all of a sudden have normal blood sugar without medicines, whereas before your blood sugars were high, where you could not be hungry for food, whereas before you were hungry all of the time. And when you then, it makes you wonder, like, a couple of things, like, what is willpower? If we would have said a week earlier that this patient did not have any willpower to manage his disease, and where people were blaming him for not trying hard enough. And now we've done this intervention on the gut, and all of a sudden, whatever willpower means in this context has now miraculously returned, and he's doing just fine. And makes you think that maybe the disease is not like patient's poor behavior. Maybe there is now like this abnormal wiring that has occurred in people with obesity, type 2 diabetes. And if so, maybe that wiring is fixable by looking at the gut. I think that core insight has led to some of the most transformational change over the past decade in the management of these diseases.
Absolutely.
It's like
And so we have lots of bariatric patients watching, and there's a lot of different bariatric surgeries, and they all do slightly different things. So you may have different, I'll get comments on it. My kind didn't do that.
Yeah.
No, and they're right. But that leads you to Fractyl, right?
Right.
So tell us, so you're CEO, president,
I'm the co-founder and CEO of Fractyl Health. We're a metabolic therapeutics company. And what we are uniquely focused on is trying to develop therapeutic interventions that can prevent and reverse disease for long periods of time, for years, without the need for ongoing medical therapy. We think that offering patients an alternative that addresses the root cause of the disease can marry really well with the wonderful medicines that we have, but can slow, if not stop, that progressive nature of the underlying disease that ultimately makes it hard for these medicines to work over the very long period of time. So what we want to do is, in some sense, rewire the brain through the gut in order to be able to allow people to not, like, for the brains not to think that they need to belong at that high weight any longer, and will help those medicines work even better in the long run, I think.
So in layman's terms, the gut is sending signals to my brain.
Yeah.
Saying, feed me,
Yeah.
feed me, feed me. The world is coming to an end. I need more food.
Yeah.
And for those people who their gut works completely medically normally, it stops at a point and I regulate my body weight. For those people who don't, we gain 100 pounds because we continue to try and survive for the winters.
That's exactly right. Yeah. And so maybe the way to think about it is like, you've got circuitry from the brain into the rest of the body in order to help you control your body's metabolism. There's a lot of different parts of the body that are responsible for maintaining weight, maintaining blood sugar, and the brain's got electronic circuitry through nerves through the rest of the body. One place where it's got circuitry is to the first part of the small intestine, an area called the duodenum.
Right.
And there's a hardwired link between the duodenum and the brain so that the brain can know as soon as you've eaten whether there are foods that are going to be absorbed that might affect your weight and your blood sugar, so that the brain can immediately respond by helping regulate how hungry you should feel and what your blood sugar should be. Because when you switch from not eating to eating.
Right.
The brain has to change the whole part of the body that's focused on producing energy in order to allow you to keep active, to storing away the energy that you just ate. It's kind of like plugging in your phone battery to charge it rather than pulling out the plug and then using the stored energy in order to be able to go about your day-to-day work, your day-to-day life. So the brain works in the same way. It's got to know when to be charging the battery and when to be using up the energy that's stored in the battery. And the gut is the first place that helps the brain know, hey, the body's getting plugged in for more energy right now.
So for people, because we have a lot of viewers who have dieted over and over and over again for 20 years, 30 years, how does that impact the brain-gut connection and how it's working?
I guess I want to start with what happens in the first place. So when people eat diets that are high in fats and sugars, we now know that there are changes that take place in the gut lining and in the duodenum itself that screw up that hardwired link and make it hard for the brain to sense that food is coming into the body and make people feel hungry all of the time and drives people to a higher weight. Well, you can imagine that if people now have this circuitry that's misfiring, they think they're hungry all the time and they eat, but they don't feel full after eating, unlike say friends or relatives who may not have obesity and can eat and then feel full and know when to stop. People with obesity have a harder time doing that because that circuitry isn't working.
Yeah.
Does that resonate with your prior experience before you launched Tirzepatide?
Absolutely.
So then the question is, now you diet, what you're trying to do is you're trying to override that circuitry, right?
Yep.
You're trying to force yourself to consume less, but the brain thinks you belong at that heavier weight.
Right.
So it's going to do two things that is going to make it very hard for that diet to be successful. It's going to make you feel incredibly hungry because it thinks you're starving. And number two, it's going to lower your basal metabolic rate because it's going to want to try to conserve energy again because it thinks you're starving because that circuitry is messed up.
To me, the analogy is it's like trying to hold your breath underwater. I
Exactly.
can do it. I can lose 20 pounds. That's not hard. Give me a month, I can lose 20 pounds. That's not hard. However, I have to come up for air.
You're fighting physiology, right? And unlike say cigarette smoking or alcohol, which some people struggle with, right? You need to eat. You can't.
There's no
not
choice.
Eat.
We
There
can't
is
just
no
go cold
choice.
turkey.
You can go cold turkey on food. And so as a result, your relationship with food has to constantly fight the physiologic battle of your brain trying to get you back up to whatever weight you're at.
I mean, it's going to keep us alive. Its sole goal, right, is to survive.
We've evolved to protect ourselves from starvation, not to protect ourselves from obesity. And so the whole brain, the whole way the body works is about making sure there's enough food in the system. And if the brain is tricked into thinking that there's not enough food in the system, then it's going to be fighting all of your dieting efforts. And that, in some sense, is what brings us to what we're trying to do. Before going
So tell us
detail,
about the therapies, because you've got a couple of cool ones you're working on.
Yeah, I mean, the lead product that we're working on is a candidate called Revita. And what Revita does is it tries to fix that hardwired circuitry from the gut to the brain by changing the lining of the gut so that it can sense nutrients normally again and send the signal to the brain that food's coming and that you should feel full again. This portion of the gut called the duodenum is such a critical player in helping the brain see nutrients coming in, and it's not working in people who have obesity and or type 2 diabetes. And so what we do, go ahead.
And so to be clear, we're not sponsored by Fractyl or anybody else here.
Yeah.
We're just bringing you stuff,
Yeah.
cool stuff. But so what? Is it endoscopy or is it through the mouth or through the?
It's an endoscopic treatment through the mouth. And
Right.
most people above the age of 45 have seen a gastroenterologist and have undergone
I've had both ends.
both ends. Yeah. So this is from the upper end.
Right.
So you don't need to do that prep,
Right,
but
no
you
prep.
do need to go into the
That's a
GI
shorter distance, I guess.
Shorter distance,
Right.
yeah, exactly. And just can't eat anything after dinner the night before. Go in through the mouth, and then we've developed a system that the GI doc can use to go treat that area of the gut, the diseased area of the gut, very precisely. We deliver a dose of energy that is meant to help remove the unhealthy lining. And what ends up happening is that unhealthy lining gets passed. Okay?
So I'm a lay person, not a doctor, right?
Yeah.
So are you essentially cauterizing?
We are cauterizing it in a very,
Very minor. That word sounds rough. I know.
Yeah,
I know.
in a very precise way,
Right.
in order to not damage any deeper structures.
Okay.
And in order to be able to help the body remove that unhealthy lining, cauterization
Right.
we can use, and then what the gut lining repairs itself
Right.
like your skin from an injury. So a healthy new lining can grow back in its place. And what we have observed in animal models is that when you remove that unhealthy lining and allow the regrowth of a healthy new lining in its place, then the body can begin to respond normally to food signals again, can begin to feel full. We've done now clinical trials in hundreds of patients.
Right.
And what we keep hearing consistently is that it is easier for patients to follow the diet they know they're supposed to follow because they're not craving those high-fat, high-sugar diets nearly as much anymore.
So is it an additive treatment to a GLP-1? Is it a standalone treatment? What? If I'm a patient, how would I see that?
We have come in the last couple of years to think about GLP-1 as a potential backbone therapy in obesity and type 2 diabetes.
Right.
You'd agree with that, right?
Yeah, sure.
We also know that diet and lifestyle is a backbone therapy. Like, you've got to do it no matter what. We see Revita as another potential backbone therapy. It can
love that.
do
Yeah.
what GLP-1s and diet and exercise cannot do, but it can make them all work better. Some people are going to diet and exercise, and that's all they're going to do. Some people are going to do a GLP-1, that's all they're going to do. Some people are going to do Revita as a standalone therapy, but they're all going to work better in an ecosystem together, because what Revita can do, which the drugs and dieting can't do, is they can begin to turn around that abnormal wiring that's driving the underlying disease process. So then if you then diet and exercise, it's going to be easier. You're going to be able to follow it longer. Everyone I know who has obesity knows how they're supposed to be eating. But everyone I know also struggles because it's like trying to hold your breath underwater.
Yeah.
What if we could take away that strong drive that's abnormal and help you rewire your relationship to food?
I think it would be exciting, man.
And then, of course, you would pair that with medicines, because the medicines are clearly really good. Now, not everyone can be on medicines all the time for a variety of different reasons. So what if we could just think about flipping the script, fix what's wrong in the body so that diet and lifestyle can work on top of it, and then layer medicines on top of that in order to cement in the benefit.
So what phase are you in for Revita right now?
So we have 2 studies underway, one of which is in type 2 diabetes, which is in the device world, we don't call them phase 3, but it's the equivalent of a phase 3. It's called a pivotal study. So in type 2 diabetes, and we have another one in obesity. And in obesity, we're very excited about the study and some of the results we've been seeing so far. What we are testing as our first opportunity to evaluate Revita in obesity is if Revita can function as a safe and effective off-ramp from GLP-1.
So for maintenance.
So for long-term weight maintenance. Because we know there are many people who start GLP-1s, but for one reason or another cannot stay on them. We also know there's
cost, whatever.
Side effects, cost, access, muscle changes. We also know that there are many people who are on a GLP-1 who have plateaued their weight loss and are asking, do I have to take this for the rest of my life, or is there an alternative? And right now, there is no safe and effective off-ramp. Revita has achieved breakthrough device designation from the FDA. The FDA has designated it as breakthrough designation.
So they'll speed it. They're saying they'll speed those through the system.
As a potential off-ramp.
Very nice.
And we have shown the equivalent of phase 2 data just last month as an off-ramp that looked incredibly exciting. And we've fully now enrolled our pivotal study, or our phase 3, and we expect to see our phase 3 results next year. So this is on the horizon in the near term.
So 2-3 years out, you could be in market and... No, you're a CEO. Don't let me get you in trouble.
Yeah, exactly. Well, because we anticipate filing for approval with the FDA by the end of next year.
Oh, exciting.
Yeah.
And if they're going to do approvals fast, we'll see.
Yeah, exactly.
We'll see. I haven't seen any yet, but we'll see.
Yeah.
So it removes the lining.
Yeah.
So over time, would I have to have it done again 5 years from now, 10 years from now?
So a healthy new lining comes back in its place within a couple of weeks. But during that time, people really don't feel anything because there's no pain fibers there. So it's just normally healing, but you don't even know it. What we've observed in real world use and in clinical studies is that in Europe, mostly, that people who undergo a one-time Revita intervention will have benefits in blood sugar and body weight that look just as good 2 years out.
Oh, okay.
As they did 1 month and 3 months out. So the nice thing about how Revita works is like, it's a little bit different from, say, starting on a Tirzepatide type drug. Where you perform this procedure once, you do have to go on a modified diet for a couple of weeks as your body heals from the procedure. But most people are almost everybody is back to their daily life within a couple of hours of this procedure being done. Like right afterwards, they go home. We don't restrict them in any way, other than we modify their diet and get them back to a normal diet over several days. Okay?
I think that's cool.
And then you watch the weight and the blood sugar just come down. Remember I told you about my patient on a bariatric surgery?
Yep.
Like that. Blood sugar and body weight come down. And by 1 or 3 months, body weight has stabilized. And 2 years later, people are still at that lower body weight.
Right.
That's different from like when you say, I want to start on Tirzepatide, because we start on Tirzepatide, they're going to give you a 2.5 milligram dose. You're going to do that every week for 4 weeks. And then you're going to go up and then you're going to go up. And it's going to take you like 4 to 6 months to really begin to see the effects as you're titrating up on the medicine, assuming you titrate up rapidly. Revita's effect is a little bit different. It's like a one-time intervention. You see those results within 1 to 3 months, and then it's stable thereafter.
All right. So the hard question is always, can I afford this? What's this gonna? I mean, is insurance gonna cover this?
Well, of course. I mean,
you want it to. I know.
We see the expenses of GLP-1 related medicines as a fundamental crisis for the healthcare system.
Absolutely.
Wonderful medicines, but the total burden is perceived by many insurance companies to be like a top 2 or top 3 problem to their health plans.
I mean, we've paid for every dose out of pocket. So I could have had bariatric surgery covered almost 100%.
Okay.
They wouldn't pay for a dime of GLP.
Okay. Part of the reason why I think they're not paying for GLP-1s is not just because it's expensive, but because if you decide that you're going to leave their plan or stop the medicine for whatever reason, then you're at very high risk of regaining all of that body weight back.
Absolutely.
And we think whatever cardiovascular protective benefit, kidney protective benefit you get while on, metabolic benefit while on the GLP-1, goes away when you stop taking the medicine. So this off-ramp or weight maintenance is not only like a critical need for patients, but it's a critical need for the health system to protect from losing all of that hard-won benefit that people experience while on the therapy.
So have you guys had any early conversations with the insurance companies and stuff?
We have.
Are they hopeful? Are we?
Well, we've been doing research with payers, and one thing that we hear is that payers absolutely see the need for maintenance as a hugely important problem to be solved. And they really seem to very much like our pivotal trial design. And if it can report out what we expect, we think we're going to have a very, very compelling story for them.
Well, they seem to understand actual physical surgical things a little bit better.
And they're covering
something that just works
surgeries.
and they don't have to continue to pay for.
Exactly. They can collar their GLP-1 risk exposure from a cost standpoint, if you can think about it.
Yeah, no, that makes sense.
Yeah.
I like it. So, okay, therapy number 2? Because I know you have another one.
Yeah. Well, therapy number 2, well, let me think about it this way. Like, let's say you need to stop or want to stop a GLP-1. Revita could be a great option for you. Maintain the body weight, maintain the metabolic benefit without needing to stay on therapy. What if there were a way to imagine a fundamentally, profoundly better GLP-1? What would that look like? Okay. I would think that would look like the following, and you can tell me if you agree or not.
Sure.
It's got to be as effective or more effective than the best-in-class GLP-1s.
Okay.
It's got to be as long-lasting or longer-lasting than GLP-1's effect on blood sugar and body weight if you stay on the therapy.
Right.
It's got to not have the GI tolerability side effect issues of the GLP-1 drugs. And it's got to be one-time administration.
Ooh. Okay. Yeah, I'm with you. Okay.
That's what we're envisioning with our Rejuva platform. And we have 2 candidates there, 001, Rejuva 001, Rejuva 002. Now, these are all in preclinical testing. They are not yet in the clinic. But Rejuva 001, we anticipate dosing our first patients in our first in-human study and reporting our first human experience next year in 2026.
But so, because we went over that one-time administration really quickly.
Yeah.
One time.
Yeah.
Essentially, you're talking about healing the disease of obesity.
We're talking about healing the disease of
Not
obesity.
treating it, which is what GLP-1s do, right?
Yeah.
They're really good at it as long as you take it. They treat it.
Yeah.
But one-time administration that heals it, it's groundbreaking.
Yeah. And so how would you, it is groundbreaking until you say, look, there are certain types of bariatric surgery, like say a Roux-en-Y gastric bypass, that can heal the disease of obesity for many people, but it is pretty invasive. And it has a lot of side effects associated
And I'll
with
tell
it.
you, we talk to people every day who 10 years out have worked around it and gained the weight back.
Yeah.
They just figured it out and their biology went, nope.
Yeah. So what we are doing is we're aiming to sort of like replicate or improve upon what you can get from the hammers that we have today,
Right.
semaglutide and tirzepatide, with an administration that's less than 10 minutes, where we are delivering the drug candidate directly to the pancreas. And what we're doing is we're teaching the pancreas how to make more GLP-1 hormone when the body needs it. So let's unpack
Yeah,
that.
I got to think about that.
Let's unpack that. GLP-1 drugs are mimicking a natural body hormone that is
Which
called
lasts like
GLP-1.
3 minutes, right?
It lasts a very short amount of time.
Yeah.
Its levels go up and down throughout the day in response to what you eat. And that GLP-1 acts in the pancreas to lower blood sugar, acts on GLP-1 receptors in the nervous system to lower your body weight. That's what we understand about the GLP-1 drug.
Yeah.
But the GLP-1 hormone works from the gut, acts locally mostly, and also affects body weight and blood sugar. Right?
Yep, I'm with you.
What we are doing is we're teaching the pancreas to act like the natural GLP-1 hormone that comes from your gut, but just to make more of it.
So you're training my body to better manage itself.
Exactly. And what that means is you get all of the potential benefits of GLP-1 as a mechanism without needing to keep taking the medicine. And what we've observed is it seems to be as effective or more effective in its magnitude of effect, its potency, we say, compared to semaglutide.
Right.
In a diabetic animal model, if you give semaglutide chronically, or you do our Rejuva treatment once, the effects on blood sugar are longer lasting in those who get our Rejuva treatment once than they are in animals that get chronic semaglutide. So not only is it a deeper effect, but it's a longer lasting effect on the disease.
And so where are you in trials? And
We've completed all of our preclinical testing. We've completed all of our preclinical development. We are in the process of filing to begin a first-in-human study.
okay.
And we're initially going to run clinical studies in Europe and in Australia.
Okay.
And we anticipate our first human studies, patients being dosed within the next several months.
So I immediately got 15 comments that said, how can I get into human studies?
Well, one question I often get from people who are not people who live with obesity or with diabetes is, that sounds scary. Like, what? No one would want that. Don't you want to?
Oh,
like,
they're lining up already.
Why do you say that? What is the thing that people like in industry, in the drug industry, or like doctors who manage these patients don't understand about why that's attractive?
I think what they don't understand is they're selling two things. They're not selling medicine. They're not selling science. They're selling hope. They're selling life. And if you can give people a hope for a better life, you win. No matter what the cost is, to be quite frank, you're going to win. And right now,
but let's say you're doing really well on Tirzepatide. Like, why would you line up for a study like what I just described that would give you a one and done GLP-1?
I mean, the first and most obvious answer is cost. It is prohibitively expensive.
Okay.
Even if they lower the price to $150, which seems to be the rumor going around, that's still more than a lot of people can afford.
Okay.
It still is.
Yeah.
I think there's a lot of people who still are a little afraid of big pharma, and I'm surrounded by big pharma right now. There's Lilly and Novo and everybody all around us.
Yeah.
There's a lot of people afraid of needles. There's a lot of people afraid of taking medications for the rest of their life. And, you know, although we do have 20 years of research, that's really, in the scheme of things, not 60 years, not, am I going to make it? So a one and done, yeah, absolutely. I can tell you, our people have been paying for hope in life.
What element of it is, one of the things that we firmly believe at our company at Fractyl is that we think that the highest ambition for people who are developing therapies for patients is to be able to offer the promise that you may not have to call yourself a patient. What do you think? How does that resonate?
I think it's
you?
awesome. I mean, I think right now the conversation that we have about the disease of obesity is basically the diabetes conversation of just because you're thinner doesn't mean you lose your disease. That's just a symptom of your disease.
Yeah.
So if the disease can be cured, and I can move on to focus on other aspects of health and life, and I don't know, write a book, learn how to paint. It doesn't really matter, right? But this is gone. This weight is lifted.
I observe, you know, the fact that you have this fantastic podcast and followership around Downsized. In some sense, what I find really, particularly interesting about it is how this is offering hope and promise about how to better live with the disease.
Yeah.
And to navigate life and our long life successfully with the disease. What I am proposing is that that's an incredible positive step on the trajectory, but the arc of history should bend towards eradicating disease, not towards living with disease.
Well, so let's stop there because I want to talk to them. So many people get so upset about price and accessibility and how am I going to do this for the rest of my life? So this CEO of a major medical company is working on that. And there's another 100 CEOs working on that out there. Hope is coming. It won't look like this tomorrow or the next day.
Yeah, so we're super excited. But I think the thing that differentiates us is that we firmly believe in reducing disease burden as a fundamental principle of the therapies that we aim to develop for patients.
Well, I can tell you these guys are going to love this. So you're a few years out.
Well, we are
Maybe
pivotal
5.
data next year with Revita, right? And filing hopefully next year as well. Anticipate filing next year as well. Usually, you know, you could sort of like roll the clock forward by, you know, a calendar year or so and think about when it might be available. If everything goes well between here and there, we're optimistic that it will, but I have to add in that caveat.
Of course.
And that we think will allow us to be in a position to be able to go to gastroenterologists around the country and then to be able to develop a therapy that could offer an off-ramp from GLP-1s something that could be a new backbone therapy in obesity alongside GLP-1s and diet and exercise. Where GLP-1s are fantastic and they're very good for you. The issue they have is they only work as long as you take them. While diet and exercise is critically important and essential, it's like holding your breath underwater, right?
Yeah.
You're fighting your physiology. Revita is aiming to fix that physiology in order to be able to turn that disease around. And I think that that's going to make the drugs and the diet and lifestyle work a lot better for you. And I think the combination of all those things are going to help provide better ways to live with the disease. And then the next thing, which is entering the clinic next year, we hope, which is the Rejuva one and done GLP-1 programs. We call it a smart GLP-1 because it releases GLP-1 from your pancreas when your body needs it, not when you don't.
So is it an outpatient procedure? And
it's an outpatient procedure.
Getting a shot in my pancreas, basically?
Getting a shot in your pancreas.
That sounds a little scary, but I could do it. I'm in.
10 minutes. Yeah, 10 minutes. Yeah.
I've been doing on GLP-1s for 2 years now. So at this point, I'm 100 plus shots. It doesn't matter. It's fine.
Fantastic. So that's the vision. Like if both of these things are targeting root cause of disease in the gut and the pancreas, and we think can afford like incredible new vista of opportunity for patients on top of the incredible progress that we've already been making in the last several years.
Very good. Well, so if you could tell them one thing about the future, what would you tell them?
I think what I would tell you is that we believe that
Go ahead. That's fine.
Yeah. We believe that we made incredible progress in obesity, but it's literally just day one of the innovation in the field. And what I'm particularly excited about are the therapies that are going to come that are going to make lives for people with this disease better. And I wake up in the morning and I go to bed at night thinking about my dad and his type 2 diabetes and people who struggle with the condition. And I think about how can I make life better by helping deliver therapies that can help reduce the disease experience rather than control the disease management.
Thank you. All right. So thank you for joining us.
Thank you. I appreciate the opportunity.
So if you guys want to follow his company, so tell them the company name again.
The company's name is Fractyl Health. It's www.fractyl.com. And if you want to follow along or if you're interested in participating in potential clinical studies, send us a note at info@fractyl.com. Again, that info@fractyl.com.
And we'll have them back on as they make new announcements because I know you guys are excited to learn more about this. All right, so that's it for this interview today. We'll have some more coming up. Please, if you haven't already, take a moment to like and subscribe. My name is Christopher Durham, and we are the Downsized.